And we're going to hear from Professor Rob Hollard, Professor of Oncology at the Marsden, about the guidelines and muscle-invasive disease.
So thank you very much. There's obviously, when we talk about muscle-invasive disease, there's advice for the urologist and there's advice for the oncologist. I'm focusing, even though I'm an oncologist, on what I believe is most relevant to a urology audience. Just to emphasise that we've got a 10-minute talk and it took us 2 years to develop these guidelines, so I can't cover everything in that time. I do recommend you at least read the recommendations, which are on the NICE website, and if you want to know about why we decided to do something, there's quite a detailed evidence review on the accompanying document. And just to emphasise what Bill was saying, the offer and the consider criteria. So I'm going to talk about patient support, the diagnostic pathway, the use of neoadjuvant chemotherapy, the decision of cystectomy versus radiotherapy, how you should do the cystectomy, and something about palliative care. One of the things that was very clear when we were going through this, and very strongly advocated both by our GP and patient representatives, was the importance of patient information and support, which was perceived to be extremely low in urology patients generally and bladder cancer specifically. And this has led to our patient satisfaction surveys giving bladder cancer patients one of the worst raps. And there's a key element of this is to try and improve that. So this is an offer support. This is probably one of the things that may have the biggest impact on your services, is that you should offer clinical nurse support to every patient with bladder cancer and also get them to assess the patient on a regular basis through the course about what their information and support needs are using the holistic needs assessment. And I guess that would be something very different to the way many patients are managed nowadays, currently. In terms of the diagnostic pathway, we looked at the evidence and suggested that actually if you get imaging before TURBT, it becomes much more accurate, much more useful. And so we have a recommendation, it's a consider recommendation, to try and do your CT or MRI staging for patients you suspect have muscle-invasive disease prior to their TURBT. And also for patients with locally advanced disease, T3B, T4 or node-positive disease, go sort of do PET imaging on the evidence that this is much more likely, because it's quite likely to pick up additional metastatic disease and is probably more sensitive than standard imaging. So do your imaging pre-TURBT, do PET afterwards if you've got high risk or disease. And the pathway would look something like this. If you're in a haematria clinic and you've done a cystoscopy and an IVU, then do a CT chest, abdomen, pelvis, including urography prior to TURBT. If you use a CT urogram as part of your screening, then do a chest CT scan, and then a PET CT scan in the high-risk patients. Neoadjuvant chemotherapy. From an oncology perspective, this isn't a surprise, but there was a very strong steer that patients should routinely be offered neoadjuvant chemotherapy. And the only reason for not doing that is if the patient wasn't suitable to receive it, or if it wasn't indicated, for instance, you're doing a cystectomy for T1 disease. And in those circumstances, if you can't give it beforehand, then do consider it afterwards. But the after should not be a substitute for doing it before cystectomy. And that's based on level 1 evidence from meta-analysis and clear benefit and advantage. I see there's a presentation here showing that same advantage in a retrospective study in the UK. What about surgery or radiotherapy? We had a debate yesterday afternoon about this to some extent, but we said we need to offer some treatment to all patients with muscle-invasive disease. I think we'd all sign up to that. We couldn't actually define any evidence that one treatment or modality is better than another. So the recommendation is that everybody should see someone who does radical cystectomy and someone who does radiotherapy to get the information as to what the pros and cons of that approach is and the relative benefits for them, so they have a fully formed discussion and choice as to how to proceed. For those patients going forward for cystectomy, I'll defer to my colleagues on the stage for this, but actually the recommendation was very much that everybody who is having radical cystectomy should be considered whether or not they're suitable for a reconstructive surgery. and that should be done in anyone unless there's a strong contraindication to some form of continent urinary diversion, and they should have the opportunity to talk to a specialist who delivers that treatment, a specialist nurse and other patients regarding that. And the aim here is to allow everyone to have that opportunity and to reduce the variability, and in general the feeling and reports were that the uptake and the offering of this was relatively low in the UK, and we wanted to improve that area. For follow-up, we put in a follow-up schedule. There wasn't very strong evidence as to what the best way forward is, but there's a lot of variation, and we felt by providing a template follow-up schedule that we could harmonise follow-up. From an oncologist point of view, particularly we were looking at the idea of doing follow-up CT imaging at 6, 12 and 24 months. And then there's advice as to how to follow patients up, both in terms of the general effects of post-cystectomy, monitoring the upper tracts, and also monitoring the urethra. One of the areas we would like to give stronger recommendations for is in the management of toxicity, both after BCG and after radiotherapy treatment. But the evidence in this area was extremely poor, and there wasn't really anything that we could give advice as to what the best way of moving forward would be. So what we, after much debate, put in the recommendation is that we should be trying to centralise the management of these patients in specialist teams, and so that they can get better experience and maybe hopefully build on that an evidence base to actually take things forward and improve things. This certainly was considered an important area for patients and patient care. The other area that I think was considered extremely important was the issue about how to care for patients at the end of life and palliative care. There's a number of recommendations about symptom management, bleeding, obstruction, such like. We'll go into details. But one of the things that was particularly important is seeing urology and urologists at the centre of delivering of palliative care. That there's a responsibility from the urology team to explain to the patient they can't be cured, to actually discuss the options with them, and to be involved in the management of symptoms at the end of life. And it was noted that end-of-life care in bladder cancer is associated with many admissions to hospital, is extremely expensive, intensive treatment, and that we perhaps could do that better. And there's also a recommendation to involve palliative care at an earlier stage in these patients and ensure that patients get an appropriate palliative care referral. So that's what I was going to discuss at the moment. I should say there were advice regarding using chemotherapy for patients with metastatic disease, both first and second line, and using radiosensitizer with radiotherapy, but I didn't think that would be of great interest to you guys here. I would say the bladder cancer guidelines are a product of much hard work and careful thought. I think that if we do implement these guidelines, we will enhance our patients' care. And if we don't embrace it, the quality standards will follow and are planned to be published later this year.
Rob, thank you very much. That's very clear.